good evening, everyone. My name is Mariam, and I'm the Education Manager of the ERN-EuroBloodNet. It's my great pleasure to welcome you on behalf of the ERN to this 5th webinar of the topic on focus on constitutional thrombocytopenia. So this series is an accredited European online educational program that targets health professionals, and that is organized by the ERN-EuroBloodNet in partnership with the CRPP, the French Reference Center for Inherited Platelet Disorders, and the Filière MHEMO, the French Constitutional Bleeding Disorders Network. The program consists of a cycle of 15 webinars developed in collaboration with 3 experts who we have attending with us tonight, Professor Marie-Christine Alessi, Dr. Saultier, and Dr. Mathieu Fiore. Professor Alessi and Saultier are from the Assistance Publique-Hôpitaux de Marseille, a member of the ERN, and Dr. Mathieu Fiore is from the CHU Bordeaux. Our goal with this program is to disseminate up-to-date knowledge among interested hematologists, internists, pediatricians, or other healthcare providers to increase visibility of the cutting-edge advances in the field of constitutional thrombocytopenia. So before we start, just note that the session is recorded and will be uploaded in the EuroBloodNet e-learning environment. If you do not wish to appear, just turn your camera off and change your name on the platform. Be also kindly informed that your microphone is muted. If you have any questions about the presentation, just use the Q&A button at the bottom of your screen, and they will then be answered after the presentation by both our expert speakers that we have with us tonight. So as mentioned, this program is accredited by continuing medical education points that are issued by the European Body of Accreditation in Hematology. You can request 1 credit per session or 15 credit if you followed the whole program. To request those credits, just make sure your name and surname are visible on the platform. Then fill out the survey, the attendance survey that I will link in the chat. And finally, just answer the 3-question satisfaction survey that you will receive after the webinar. So today, it's the 4th webinar of this series. Join me in welcoming Doctors Lozano and Rivera that we have with us tonight, who will lead this lecture on MYH9-related disease. So Dr. Lozano is Associate Professor of Hematology at the University of Murcia, an attending physician and head of the Hematology-Oncology Department at the Meseguer Hospital, and director of a regional blood bank in Murcia. She's also a member of the Rare Diseases Networking Biomedical Research Center, CyberRare, and Professor Lozano's research interest lies in the area of inherited and acquired platelet disorders and cellular therapy product collection and processing. Dr. Lozano has authored or co-authored more than 160 manuscripts published in international peer-reviewed journals. Our second speaker tonight is Dr. Rivera, who's a member of the Blood Transfusion Center of Murcia, where he is responsible for the quality system and blood processing departments. Dr. Rivera is also Associate Professor in the Department of Internal Medicine of the University of Murcia and Senior Investigator of both the Biomedical Research Institute of Murcia and the Spanish Network of Rare Diseases. He has published around 150 articles in international peer-reviewed journals. So doctors, the floor is yours.
Thank you.
Okay. So I'm going to share my screen. I guess you can see now my screen.
It's working perfectly, yes.
Perfect. So to start, we would like to thank the Professor Marie-Christine Alessi and the rest of organizers for giving us the opportunity to participate in this series of webinars to review the MYH9-related disease. These are our disclosure. And these are the points, the main points that we are going to review in this talk. So in the first part, I will comment on the general, more basic aspect of the MYH-RD. And in the second part, Professor Lozano will review in more detail the clinical feature, the management, and the treatment of the patient with this disease. So to start, let's start by a definition and general feature of this disease. So this is an autosomal dominant inherited thrombocytopenia caused by mutations in the MYH gene, which is the gene that encodes for the heavy chains of the non-muscle myosin 2A. This disease includes a spectrum of syndrome that has been previously classified as distinct diseases, including the Meckelman, Sebastian, and the Estein syndrome, as well as the autosomal dominant deafness DFNA17. The hallmark features of this disease are thrombocytopenia that can be mild to severe and can usually stable through life. There's also a marked platelet macrocytosis with large platelets and many GM platelets. And it's also typical the finding of inclusions of the NN heavy chains 2A protein in the cytoplasms or granulocytes. And these are seen as basophilic dolle-like bodies in conventional blood smear examination in about 50% of the cases, or as aggregates of the MYH9 protein after immunofluorescent staining of the blood smears. Bleeding in this patient is usually mild and can be influenced by the platelet count, and the platelet function is assumed to be normal. The important issue is that most of these MYH-RD patients develop late in life extra hematological features, mainly sensorineural deafness, kidney disease, presenile cataracts, and benign elevation of the liver enzymes. So as happens with other inherited thrombocytopenia, we do not have proper population studies. So the real frequency of this inherited thrombocytopenia is not known. However, it is considered as one of the most frequent forms of inherited thrombocytopenia worldwide, close to together with the ankyrin 26-related thrombocytopenia, the monoallelic vernaculaire syndrome, and the actinin 1-related thrombocytopenia. In a large series of patients studies in Italy by Pesci and Balduna, they found that this MYH-RD is the second most frequent cause of inherited thrombocytopenia in Italy, just behind the monoallelic vernaculaire syndrome, which is the first one in Italy because of the founder effect of the Lozano variant in GP1B alpha. In France, according to the more recent data of the Reference Center for Platelet Pathology that kindly provided Professor Alessi to me, it has been shown that this inherited thrombocytopenia is the most frequent, representing about 26% of the cases. And in Spain, our group of the Spanish group of inherited platelet disorders, we manage a series of 236 patients with genetic diagnosis of inherited thrombocytopenia, and MYH-RD represents the second most frequent one, 12% of the cases, just close to the RANES1-related thrombocytopenia and the tubulin beta-1-related thrombocytopenia. To my knowledge, there's no prevalence variation across ethnic population. And the estimated prevalence of this disease, it's about 3 to 5 cases per million population. But this prevalence is likely and underestimated, as many mild patients can be identified only incidentally, and many patients might also be misdiagnosed with other diseases. In fact, in a study published in 2019 by Fernandez Perez et al., they reported a 10 times higher prevalence of this disease according to the frequency of MYH genetic variant found in Genomat and the finding of 5 unrelated family in a region, in the Greenswald region in Germany, in a population of only 250,000 people. As for other inherited platelet disorder, the diagnostic process should start with an appropriate clinical assessment, looking especially to the duration of the thrombocytopenia, the presence or absence of acquired causes of thrombocytopenia, the family history, including bleeding, and of course, the presence of or absence of associated extrahematological features, mainly kidney ulceration, deafness, and cataract. As concerns the laboratory diagnosis, we will make special attention to the number of blood cells and the shapes. If we do automatic counting of the completed blood cells, we might find very low platelet numbers in some patients. But we have to be aware that these automatic counters normally fail in detecting platelet macrocytosis. Therefore, more realistic estimation of the platelet number and shape might require other methodologies. For example, flow cytometry assessment of the platelets. By this technology, we will easily observe that the MYH-RD platelets are much bigger than the normal one, and the platelet count can be up to five times higher than the numbers that we might find in automatic counters. Also, a careful examination of the blood smear is almost mandatory in the diagnosis process of this disease. By examination of this blood smear, we can recognize this reduced number of platelets, the presence of GM platelets, and also we can detect the presence of these doll-like bodies in neutrophils. And of course, this simple test might be enough to a precise suspicion of the MYH-RD diagnosis, and thus preventing a misdiagnosis that has been reported to happen in up to 50% of the patients. And more importantly, to prevent the inappropriate treatments like steroids in about 30% of the cases in some series, or even harmful treatment like splenectomy in 10 to 15% of the cases. These doll-like bodies might be fine and not observable. Might not distinguish them in the examination of standard blood smears. However, they become easily detectable by immunostaining of the blood smear with appropriate MYH specific antibodies, as you can see here. And also, we can detect this overexpression of the MYH protein in the periphery of platelets, as you can see here. So many groups have already used this in this IF immunostaining procedure, and they have proved that these methods might have 100% sensitivity and specificity for the diagnosis of MYH-RD. In a previous webinar in this series, already Professor Andreas Gereinake demonstrated the value of this immunofluorescent analysis of the blood smear in the diagnosis of several inherited platelet disorders. In collaboration with him and other colleagues in Denmark, Germany, and Spain, we have done a blinded assessment or validation of these methods in a series of inherited platelet disorders. And as you can see here, we also include MYH9-related disease patients. And in this case, in 5 out of 5 cases, we were able to detect the GM platelets and the doll-like bodies and the aggregates of the MYH protein in neutrophils. I like also to mention that a careful examination of the blood smear might also reveal abnormalities in shape in other blood cells. And that is the case of the red blood cells, with the appearance of these elongated red blood cells. And the numbers of these elongated red cells seems to be related, as for other phenotypes, as I will comment later, with the type of mutation that carry the patients, with a greater effect of those variants that affect the head domain of the protein. And to end this part, in this diagnosis part of my presentation, just to say the platelet function testing is considered of limited value in the diagnosis of MYH-related disease. We have recently performed in the Spanish group of inherited platelet disorder multicentric assessment of the platelet function in a series of around 100 patients with genetic diagnosis of inherited platelet disorders. And we have also included in this study a few MYH-RD patients, 6 patients. And as you can see in these plots, we found no significant differences in the glycoprotein expression level, the activation of the platelets, or the secretion of the alpha and delta granules in this patient as compared to the control. We also did not find differences in the PFN 100 test. However, when we did platelet aggregation studies in this patient, we found a mild but consistent reduction in the platelet response to several agonists in patients compared to the control. And in this multi-test study that we have performed, we have also used the most novel TTAS total thrombus formation system. And when we use this system that measure the formation of thrombus in a sheet in whole blood and the high shear rates, we observe that using the AR and HD chip, which measure thrombus formation depending both in the coagulation and the platelet function, there's not differences in the results of the test between the MYH-RD patients and the control. However, when we did the same test, but using the PL test, the PL chip, we found a significant reduction in the results in the MYH-RD patients. And of course, this value might be influenced by the platelet number, but I have to say that, for instance, the reduction of this test is also very pronounced in DIAP1-related thrombocytopenia, which have higher numbers than those patients. So this assessment might indeed reveal that there might be some degree of platelet dysfunction in these patients that might contribute also to the bleeding tendency. Right, so myosins are a large superfamily of proteins that use energy from ATP hydrolysis into unconformational chains that propel molecular motions. To our knowledge, there are 15 different classes of myosin, among which myosin class 2 has been the only one known for decades, and it was referred as the conventional myosin. This class 2 myosin form filaments and create force and tension because their motor domains bind to actin filaments. Class 2 myosin are classified in 2 groups: the muscle myosin 2, including the skeletal, cardiac, and smooth muscles that are involved in muscle contraction, and the non-muscle myosin 2, which are involved in cell contractility, morphology, cytokinesis, and migration. And there are 3 different isoforms of this non-muscle myosin 2, depending on the type of heavy chains that are each in the molecule. Either the form isoform A, B, or C, which are encoded by the MYH9, 10, and 14 genes. And these 3 genes, despite being different, are share a considerable homology and have sub-overlapping function, suggesting that they have evolved from duplication of an ancestral gene. In vitro analysis of this isoform have also shown differences in the enzymatic property, subcellular localization, molecular interaction, and tissue distribution. And to our knowledge, this myosin heavy chain 2A is the most distributed one isoform, and is the only that is present in platelet and in most blood cells, except macrophages. And as concerns the megakaryocytes, until recently, we thought that this myosin 2A was also the only isoform expressed in megakaryocytes. But now we also know that immature megakaryocytes express also the isoform-V, the MYH10 protein, which, however, is downregulated during maturation of the MKs until disappear in the terminal platelets. The MYH gene, it's a large gene located in chromosome 22q, spanning 106 kilobases and comprising 41 exons. This gene the analysis of the promoter region of this gene suggested that this is a typical housekeeping gene, lacking the data box and containing a large number of GC boxes. This is a well-conserved gene through evolution since from fungi to mammals, and the mouse ortholog MYH9 is located in chromosome 15 and has a similar gene organization as the human one, and also encode for a protein with shared 90% homology with the human protein. And that's why the mouse is so a good model to study the MYH-related disease, the mechanism of the disease, and also the impact of the human mutation found in patients. The open reading frame of this gene expand from the exon 2 to exon 41 and encode for the protein with 19660 amino acids, which is the non-muscular heavy chains 2A. And as happened with other class 2 myosin, this NM2A protein is an hexameric molecule that contains 2 heavy chains and 2 pairs of light chains, the regulatory and essential light chains. The protein contains an N-terminal domain, including the globular head and the neck, and then the coil rod domain that ends with a non-helical tailpiece, very short one, encoded by exon 41. The motor domain is responsible for the actin binding and for the ATPase activity. And the three-dimensional structure shows that it contains an N-terminal domain, the upper and lower 50 kilodaltons domains, and a converting domain. The neck is responsible, acts as a left arm that enhances the movement derived from the conformational change in the motor domain, and serves also as the binding site for the regulatory and essential light chains. The C-terminal tail is responsible for the dimerization of the heavy chains to form this long coil rod domain that allows the formation of the functional hexameric molecule. At the end of this region, there is a assembly critical domain that is positively charged and allows interaction with negative parts in other coil core rods domains in other hexamers, allowing oligomerization of the myosin. And this C-terminal region ends in a very short non-helical tail with only 34 amino acids, which is very variable and among the different isoforms, and controls also the activity of the unit. And it seems that this region is also participates also in the distribution, the tissue distribution of the different isoforms. So class 2 non-muscle myosins per ABC participate in processes, very important processes requiring force production and translocation of the actin cytoskeleton, such as cytokinesis, cell migration, polarization, adhesion, maintenance of the cell shape, and signal transduction. The M2A is present in a large variety of cells during the early embryonic development, representing up to 80% of the total class 2 myosin in these cells. It seems to have a key role in the formation of the functional visceral endotherm in a function that seems not required the full motor activity of the protein, and therefore it can be replaced by other isoforms. And it is also very important, at least in mouse, for the placenta formation in a function that in this case requires the full motor activity of the protein, and therefore cannot be replaced by the B or C isoform. The in vitro analysis of this isoform has shown that the highest actin activity, ATPase activity, and the highest rate of sliding actin filaments is for the 2A isoform. But this activity is much lower than that of the muscle myosin 2. Therefore, it seems that this 2A isoform is well designed for quick processes that require small-scale forces and dynamic filament assembly and disassembly, for example, as happened in migrating cells. And when we consider the existence of a specific function for each of these isoforms, we have to take in mind that many cells and tissue express different isoforms in variable amounts. So among this isoform, it is the isoform 2A, the most distributed, and is the only one in the spleen, and as I said before, in platelet and in most blood cells. But in cells that contains the different isoform, if they are co-present, this isoform can exert their own function, but they can also co-assembly in intracellular into heterotypic filaments, and therefore they can be performing both isoform-specific and isoform-redundant functions. The MYH9, it's a very regulated protein, and that's probably reflects the importance of the function. There are two major regulation mechanisms. One is the conformational switch of the protein, and the second is the phosphorylation of the heavy chain and its interaction with other proteins. So as happened with other myosin, this myosin 9 has two different conformations: a folded inactive 10S form and an active unfolded 6S form. And the transition in these forms allows the increase in the ATPase activity, the sliding of the actin filaments by biopsy. But this transition is mainly controlled by phosphorylation of specific residues, amino acids in the regulatory light chain, especially serine 19 and threonine 18, which is made this phosphorylation by kinases like MLCK of the ROCK, which is a RO kinase. The active form is rather unstable, and it either interact with other 6S form to stabilize, or goes back to the inactive conformation. And that happened mainly by the phosphorylation of this residue that take place by the phosphatase 1, which activity is also controlled by phosphorylation by ROCK. On the other hand, the assembly and disassembly of the filaments is also controlled by phosphorylation of the heavy chains in several amino acids in the C-terminal end by kinases like protein kinase C, the casein 2, or the TRPM7 kinase. And also the interaction of these heavy chains with other proteins like the calcium sensor S100A4, the tumor repressor LGL1, or the myosin 8, prevents deformations and favors the disassembly of the former filaments. In this slide, I just summarized the filament formation process. So this starts by dimerization of the heavy chains to form this functional hexamer, and this hexamer can interact with other hexamer in the correct active form to form these bipolar filaments. And these bipolar filaments act as a nucleation site to form these large order mini filaments, which might include 20 to 30 hexamer. So this hexamer in a cross-swinging cycle can interact with actin and use the energy from the ATP hydrolysis to slide the actin, causing remodulation of the cytoskeleton and cell motion. As I said before, this MYH9 protein, it's very important in development. And because of that, this might explain why we don't find patients with half a homozygous variant causing a full deletion of the gene or full or complete lack of the activity. In contrast, we have identified in patients around 100 different heterozygous mutations that affect differently the ATPase activity or the capacity of the protein to dimerize and for large order filaments. Most of these variants are missense variants that are mainly localized in this exon that you can see here. And in contrast, the nonsense splicing, duplication, and inferred deletion are more rare and normally are located at the non-tail end, non-helical tail end or nearby. Also, it's important that about 25 to 35 of the variants that we can find in patients are de novo variants. So that means that the identification of a patient with macrothrombocytopenia without family history of that thrombocytopenia should not exclude the suspicion of MYH9-RD disease. In some cases, the explanation for the novel variants have been shown to be somatic or germinal mosaicles, but it's considered this is considered a rare mechanism. However, it might be more frequent if we have the chance to analyze more biological samples from the patient. An important issue in this disease is both the hematological phenotype and the risk of developing late onset manifestation of the disease and their severity seems to be dependent on the specific MYH mutation. As a general view, it's considered that the head domain variants cause a more severe clinical phenotype than variants located at the tail domain. And if we look just at the hematological phenotype, we can see that a patient that bears variants in the head domain has larger platelets and more severe thrombocytopenia than those having variants in the tail domain, and also increases number of aggregates on IF staining of the blood smear. Probably the most important or the outstanding paper and study in this context is the one performed by Pacey and co-workers in 2014. So when they studied a large series of consecutive patients with this disease and identified both the phenotype and the genotype, they were able to recognize that only 7 MYH genotypes account for about 80% of the disease cases. And these 7 genotypes provide a high, moderate, or low risk of clinical manifestation. This is also being summarized here in this table and these Kaplan-Meier plots by the authors. And as you can see here, the most dangerous variants, according to this study, are those affecting the arginine 702 in the head domain, as well as the aspartate 1424 histidine change in the coil domain, which leads to very early development in life of severe nephropathy and deafness. In contrast, variants located at the SH domain or those affecting the arginine 1162-65 in the coil domain are of intermediate risk, as they do not cause or are not associated to nephropathy, but they associate with risk of the development of deafness before the age of 60. And last, this aspartate 1424 asparagine variant, the A1841K variant, or those located at the non-helical tail, seems to be of very low risk of developing this late onset clinical manifestation. So it seems clear that because at birth, most of the patients with this disease will present only macrothrombocytopenia in variable degree. Their evolution in life will be so different depending on whether they develop this late onset clinical manifestation. And therefore, the capacity to advance the natural evolution of the disease according to this genetic diagnosis, it's very important for the appropriate clinical management of the patient. However, we should be aware that might be exceptions in this risk assessment of the variants from this study. And this is an example. This is a patient that was referred to our unit with thrombocytopenia and a misdiagnosis of ITP that led to the use of steroids and even splenectomy in the patient. The patient developed bilateral hearing loss in the first decade of the life, and also an end-stage renal disease that requires a renal transplantation at the age of 36. And unfortunately, the patient died from COVID later. So in this patient, probably this misdiagnosis and this could have been prevented by simply looking with careful examination of the blood smear that will have identified these GM platelets and this typical dolle-like body in neutrophils. Also important for the genetic counseling is that the patient has 5 children, and when they were referred to us, two siblings already presented with microthrombocytopenia, and one of the girls even with proteinuria, which remains stable currently. The unexpected finding is that when we did the genetic testing in this pedigree, we observed that the variant that we found was the E1841K variant, which according to the study by Pesci and co-workers was a low-risk variant. So the lesson from this patient is that on one side, we have to look carefully at the blood smear in patients with microthrombocytopenia, and also that the identification of a theoretical low-risk mutation in the MYH gene should not preclude a close medical follow-up of the patient with this disease. MYH-RD is a highly heterogeneous disease in terms of clinical manifestation and severity. And why is that? What are the underlying molecular mechanisms of this clinical manifestation, and why is there such a strong genotype-phenotype relationship? I'm afraid that we have not a definite answer for this question. The MYH-RD represents a very complex system that is contributed by the nature of the mutations, the amount of the proteins that is produced, and which is its functional degree, the tendency of the mutant protein to aggregate, and the potential role or participation of other heavy chain isoform or other proteins. And probably the combination of all these factors explain the heterogeneity, the heterogeneity in the clinical phenotype of the patients. And probably we are not able to find a unique, precise explanation for every single clinical manifestation. Let me just comment on the pathogenesis of the macrothrombocytopenia in this disease, which is the common feature in these patients. So as you know, and in a simple view, during the normal megakaryopoiesis and thrombopoiesis, the megakaryocytes differentiate from the stem cells in the endostellum niche in the periphery of the bone marrow. And then when they mature, they move driven by chemokines gradients to the next to the sinusoids, where they extend protrusions across the junction in the endothelial cells. And then this proplatelets, this protrusion in the sinusoids, are, when they reach a certain maturation and size, they're excited to the blood by a combination of the force of the blood flow and also the constriction between the megakaryocyte body and the proplatelets provided by the MYH protein. What happened in the MYH-RDG disease, in a simple view, is that for one side, these mutant megakaryocytes have an impaired capacity to migrate to the sinusoid. So this means that we will have less proplatelets inside the sinusoid. And this impaired migration capacity will also favor the ectopic release of proplatelets inside the bone marrow. And in second place, when for the megakaryocytes that reach the sinusoid and extend proplatelets, they cannot provide the MYH force to help the excision of these proplatelets. So megakaryocytes keep injecting material in these proplatelets for longer than normal time until these proplatelets are so big that they provide a strong resistance to the blood flow, and they are excited by the flow, regardless of the force provided by the mutant MYH9 protein. What about the mechanisms for the extrahematological manifestation? Unfortunately, those mechanisms remain poorly understood. But again, we expect that the genetic alteration in the gene will have a great influence in the development and evolution of this late onset manifestation in the patient. As concerns the nephropathy, data from mouse model for MYH9-related disease with mouse expressing different mutations that have been found in patients, as well as the analysis of kidney biopsies of patients, seems to support the idea that this mutant MYH9 protein may cause structural and functional defects in the podocytes, which are the very specialized kidney epithelial cells involved in glomerular filtration. And that results in proteinuria and progressive glomerulosclerosis. For the hearing loss, we neither know the mechanism, but it is speculated that because the MYH9 is expressed in the hair cells of the organ of the cortea, it's possible that this mutant MYH protein may cause deafness by disrupting the structural integrity of the stereocilia, which are the structures that convert the stimulus, the sound stimulus, into electric stimulus for the brain. And lastly, we also the mechanism of the cataract is also unknown, and this is normally an age-related event, but it is speculated that maybe the mutant myosin can favor the occurrence of this complication because of causing damage in the epithelial cells of the crystalline. So with that, we will move to the second part of the presentation that will be given by Professor Lozano. Marisa?
So thank you, Pepe. I am delighted to address and discuss now the clinical aspects of MYH9-related disease. And as Dr. Rivera just said, Although rare, this condition stands as the most prevalent form of inherited thrombocytopenia. Next slide, Pepe, please. So MYH9-related disease exhibits hematological features that are present from birth, such as platelet macrocytosis, where over 40% of the platelets exceed the 3.9 micrometers in diameter. Thrombocytopenia, considering it as platelet count below 100,000 per microliter, and the presence of MYH9 protein aggregates in neutrophil cytoplasm. And as individuals age, they may develop additional extrahematological manifestations, including sensory neural hearing loss, renal disease, presenile cataracts, and elevated liver enzymes. Next slide. Now, platelet macrocytosis is a consistent feature from birth. As a reminder, the electronic cell counters underestimate both platelet count and platelet size. And thrombocytopenia, the severity may vary, but it usually remains stable throughout life. And standardized questionnaires like the ISTH bleeding assessment tool are recommended to assess the degree of the bleeding of the patients. And this disease is often misdiagnosed as ITP, and that leads to ineffective and potentially harmful treatments. And we always should consider in the differential diagnosis other forms of inherited thrombocytopenia, such as Bernard-Soulier syndrome. Next slide. Pepe, next slide. Now, sensory neural hearing loss is observed in around 50% of the cases, with about half of them experiencing it by the age of 33 years. The onset is evenly distributed between the first and the sixth decades, with the earlier onset progressing more rapidly. And basic audiological evaluation includes audiometry and, in severe cases, speech recognition scores. Next slide. And glomerular nephropathy in MYH9 presents with proteinuria and microhematuria, with a median onset age of 27 years. Approximately 72% develop kidney disease before the age of 35. That often progresses to end-stage renal disease. And the blood test for serum creatinine and basic urine analysis that includes protein to creatinine ratio, and ideally a 24-hour protein excretion should be performed. Next one. And chronic kidney disease, deafness, and a family history of these manifestations should raise suspicion for rare inherited kidney diseases. And this slide lists differential syndromes and the associated genes. The main differential diagnosis is Alport syndrome that shares the features of nephritis, cataract formation, and sensory neural deafness. The two syndromes can be differentiated by the most frequently X-linked in inheritance of Alport syndrome, whereas MYH9, as we know, is autosomal dominant. And even though normal platelet counts do not absolutely exclude MYH9, when nephropathies are linked with macrothrombocytopenia, one should always consider this disease. Now, Pepe, next one. And cataracts, they typically manifest in these patients around the age of 37, mostly bilaterally and progressing over time. And ophthalmologic assessment should include visual acuity, slit lamp examination, and fundoscopic examination with dilated pupils. As for liver, the elevated liver enzymes, particularly aspartate aminotransferase, usually remains stable over time. and the normalization of the enzyme levels may occur, and really the progression to hepatic impairment is very, very rare. And there is no significant genotype-phenotype correlations for elevated liver enzymes that have been identified. Next one. And addressing the myriad challenges of MYH9 requires an individualized approach that should recognize the diverse manifestations and the severity of the genetic disorder. And multidisciplinary management should involve hematologists, nephrologists, otolaryngologists, and ophthalmologists, and the careful management of thrombocytopenia and the associated bleeding tendencies should include different interventions like thrombopoietin receptor agonists, particularly L-Thrombopac, and other measures like antifibrinolytic agents and oral contraceptives. And although short-term thrombopoietin receptor agonist is a valuable treatment for MYH9-RD in reducing bleeding symptoms and before surgery, the reports also describe that the long-term use of TPRAs in cases of MYH9 in patients that had previously been diagnosed with ITP or those that have severe bleeding and those reports indicate that the continuous treatment with these agents may be possible in a subset of these patients. And caution is always urged with medications that can inhibit platelet function. Now, next one. And to mitigate the impact of significant hearing loss in MYH9, the use of hearing aids may be recommended with cochlear implantation emerging as an effective measure for severe to profound deafness. And similarly, also caution with ototoxic medications should take place. Next one. And the risks and benefits of agents affecting renal function should be weighed, like we said. The nephropathy of this disease, the management may involve the use of angiotensin converting enzyme inhibitors or angiotensin receptor blockers to treat the proteinuria. It was suggested that the early administration of these agents could contribute to reducing the proteinuria and potentially impeding the kidney damage progression in a small case series of patients with MYH9. Next one. But in a recent cross-sectional nationwide survey in Japan of patients with MYH9, the authors confirmed that the patients with variants that affect the motor domain had poor kidney survival, similar to previous reports, but this study seemed to demonstrate that there were no beneficial effects of renin-angiotensin system inhibition on kidney function, although how early these agents were introduced was not analyzed. And renal replacement therapy is the only viable treatment for end-stage renal disease and includes hemodialysis or peritoneal dialysis, as well as kidney transplantation, with adequate attention to bleeding complications and aiming at maintaining platelet counts above 100,000 during the perioperative period. Next one. And for cataract management in this disease, this includes timely surgery, trying to avoid the use of corticosteroids. There is no specific treatment for elevated liver enzymes, but also caution with potentially hepatotoxic drugs is advised. Next one. And clinical practice guidelines for this disease are currently unavailable. And after the diagnosis, the evaluations are crucial to assess the disease extent and the individual needs. And this slide outlines some recommended periodic examinations for the affected organs. Regular evaluations include platelet counts and hemorrhagic clinical assessment. And audiometry is recommended every 3 years for those patients without known hearing impairment, while cataracts and liver function tests should be assessed at a similar frequency. And proteinuria, serum creatinine testing is recommended at least twice a year for possible renal disease progression. Next one. And genetic counseling in this disease involves providing information for medical and personal decision. As Pepe said, approximately 65% of the cases have an affected parent, and 35% are simplex cases with a de novo pathogenic variant. The evaluations for parents include the genetic and hematological testing, and sibling risk depends on the parental genetic status, and offspring have a 50% chance of inheriting the variant. And family planning and discussion regarding prenatal and pre-implantation genetic testing are essential considerations after the diagnosis. Next one. And in addition to thrombocytopenia, platelet microcytosis, Dolly-like bodies, deafness, kidney disease, cataracts, and abnormal enzymatic activity on the liver, recent evidence also suggests that the aberrant activity of this protein is implicated in the neurological diseases. Notably, MYH9 is concurrently affected in schizophrenia, intellectual disability, and also in autism. The investigation into targeting the phosphorylation of non-muscle myosin 2A is currently underway, and is exploring its potential for treating neurodegenerative conditions such as Parkinson's and Alzheimer's. And furthermore, the altered expression or activation of this protein may influence the cell migration and division, which are pivotal aspects of tumor growth and invasion. And in vitro studies demonstrate that inhibiting this protein prevents the migration and invasion of breast cancer and glioma cells. And that positions this protein as a potential target for treating highly invasive tumors. And but intriguingly, also this protein is deemed as a tumor suppressor, safeguarding skin cells against cancer development. And in addition, the protein has been associated with viral and bacterial infections, diseases, and depletion of non-muscle myosin 2A often hinders the dissemination of the pathogens. And this implies a protective role during infections by bacterial pathogens. So although this non-muscle myosin 2A appears to be a critical player in a wide range of physiological and pathological processes, making it a promising target for therapeutic interventions, the complexity of its different roles emphasizes the need for careful consideration to develop targeted and effective therapeutic strategies. Next one. And with that, we conclude this presentation. We invite you to the upcoming meeting on platelets that will be held in Murcia, September this year. And we thank you for your attention, and we will address any questions if we have time that you may have.
Thank you so very much, Drs. Rivera and Dr. Lozano, for this great presentation and for your time. We seem to have a few questions already. So I'm going to read them. They're in the chat. So Professor Saultier asks, should renin-angiotensin inhibitors be considered before the occurrence of proteinuria in patients with high-risk variants, as they may not prevent evolution to end-stage renal defect in patients with overt proteinuria?
Yeah, I agree. I think that these agents are being introduced probably too late, and that justifies the lack of effect in that survey in Japan that was published by a group that had many patients with kidney end-stage renal disease. So I agree that probably as soon as we identify these patients and low levels of proteinuria, much lower than 0.5 grams per day are being detected, or those with those mutations that predict that they will develop renal disease, I think we should start this, even though we have no evidence, but I agree that we probably starting these agents, like in any proteinuric diseases, would help.
Thank you. Dr. Fiore has asked, have you ever seen patients with MYH9 mutation without thrombocytopenia, but other complications such as kidney issues or deafness?
We have not, but we have seen all these ideas about the implication of this protein in the neurological diseases is very indirect. We have a very particular and interesting case of a child with profound and severe autism who developed all the complications related to the MYH9 disease very early, deafness at 2 years of age, and severe thrombocytopenia. So I'm sure that there will be many more other, we need big registries because, well, this is a mutation that has been described in another family with no neurological problems, but we had to try to understand what is causing the different manifestations of the mutations in each patient. But to my knowledge, I don't remember any patient with no thrombocytopenia.
Thank you. Professor Saultier commented, TPO receptor agonists should be particularly considered in these patients, still off-label in France, at risk for renal failure, and that may require renal transplantation.
Yeah. About 60-70% of the patients respond after 3 weeks. If not, we increase the dose of usually the thrombopacks drug that has been most used. And patients that are undergoing dialysis and also especially kidney transplantation are at high risk of bleeding because they bleed quite a lot. They have important complications and you have to keep platelet counts really high. So I think starting with TPORAs before any intervention that may be potentially have a high bleeding risk would be appropriate. Right now we have evidence of those patients that were misdiagnosed with ITP and have been under TPORAs for many years, and they have been, completely no complications at all. And TPORAs do not associate renal dysfunction. So I think they are safe agents to be used in this disease, even though it has to be off-label, of course.
Thank you. We have an additional question from Mrs. Poole, who thanks you both for your great presentation and asks about your opinion about TPO receptor in pregnant women for MYH9-RD.
I would try to avoid them. We are using TPORAs in pregnancy when we have no other options in really refractory patients. But it is right that sometimes we have to use them in case, usually these patients don't bleed, but in case there is very low platelet counts or the patient has, cannot increase platelet counts after transfusion, maybe I would consider them during the 3rd trimester because they are very safe in the 3rd trimester. And if I have to choose one, I would choose romiflostim because that is the one that has the lower off-side effects. So maybe for preparation for delivery in a subset of patients where transfusion cannot be an alternative, it can be considered during the 3rd trimester.
Thank you. Professor Alessi, one of the coordinator of the program, is commenting that a recent paper indicating a deleterious effect of TPO on chronic renal injury was published in 2023 in JNS. Thrombopoietin-dependent megakaryopoiesis fuels thromboinflammation and worsens antibody-mediated chronic renal microvascular injury.
Okay, I will read that paper. I mean, we have been using these agents not in MYH9, but especially in ITP for more than a decade. And I mean, there are no really significant clinical complications concerning renal disease that I'm aware of. But of course, if this has been described, maybe it's another situation and it has to be, yes, considered.
Thank you very much. So while we wait for any additional questions, I would like to thank both our speakers for being here tonight and taking the time to share their expertise with us. And also invite you to join us on the next topic on focus on constitutional thrombocytopenia that will happen on the 21st of February. That will be led by Professor Saultier, one of our program coordinators. It's going to be on thrombocytopenia due to transcription factors defects and leukemia predisposition. We have a few people, like we have both our coordinators thanking you again for this great presentation. I do not see any additional questions, so I'm going to thank you again, both of you, thank our coordinators and everyone that has attended this webinar. Thank you so much and have a great evening.
Thank you.